Hey guys, welcome to Man Medicine, the mobile edition. As you can probably tell from my background, I am not in the UAE currently. I'm actually back home here in Oregon, visiting family actually. So I wasn't actually planning on knocking out a podcast while I was out here, but I ran into a buddy of mine, one of my jiu-jitsu buddies, who is seeing a local testosterone clinic here in town. And he mentioned something that they're doing on his protocol that I just got to get it off my chest. I got to have a little bit of a rant for you guys, and I hope you actually find it useful in case you happen to be seeing a clinic that is doing the same thing. And what I'm talking about is using Ganirelix as a substitute for HCG and telling guys that it's sufficient to maintain fertility. And I'm going to explain to you why that's not the case and suggest strongly to you that if you are being given Gonadorelin by your clinic and they're telling you it's going to maintain fertility, that you turn around and walk out the door because you're not dealing with a competent or ethical provider or clinic. So my buddy and his wife are trying to have a baby, and he's done really well on TRT. Like many of us, he wants to stay on TRT while he tries to conceive a child, which is totally doable, despite what you might hear. Most men with a proper protocol do not have to come off of testosterone in order to generate an adequate sperm count to conceive a child. But they're telling him that he can take Gonadorelin in lieu of HCG. I'm not sure if they just don't have access to HCG, which is a bit strange to me because it is readily available, or whether, they've just decided to use Ganirelix in their protocol due to financial reasons. I think that's actually probably the real reason. But no surprise, they're not pregnant, and it's because Ganirelix is not sufficient in a male, especially the way that these clinics are using it to restore fertility to the point where you're going to be able to conceive naturally, except in perhaps the rarest of cases. So let me begin my little rant here. Why did clinics start using Ganirelix? It became popular just a few years ago when the FDA prohibited compounding pharmacies from making a variety of different peptides, one of which ended up being HCG. So HCG, which has been safely compounded by compounding pharmacies for decades, now could no longer be compounded. And so as it stands right now, the only HCG on the American market, this doesn't apply to you guys that are overseas or if you have access to medicines from overseas. Yeah, the only thing that's available in the US is brand name Big Pharma HCG, which is typically the Pregno brand at about 5 to 10 times the previous cost of the compounded version. So clinics started looking at the cost of that and the availability and said, well, we'll substitute Ganirelix and we'll tell guys that it does the exact same thing. And I'm here to show you that while on paper that might be the case, it doesn't work out in real life for the reasons I'll explain in just a second. So Ganirelix it's GnRH, gonadotropin releasing hormone, right? So it's produced by the hypothalamus, and GnRH stimulates the pituitary gland to release LH and FSH, which sounds great, right? I mean, you do need LH and FSH to maintain fertility. So, sounds great. I'll take some Gonadorelin. The downstream effect will be more LH and FSH, and then I'll be able to maintain adequate sperm counts to be fertile. Well, like I said, it doesn't really work out that way. So this comes down to the reason for this is because of the half-life of these of Gonadorelin, and then of course the half-life of LH and FSH as well. So Gonadorelin is rapidly, when it's injected, it's rapidly broken down by a number of different proteolytic enzymes. So they just chew it up. The half life is somewhere around 10 to 20 minutes when it's injected subcutaneously or intramuscularly. It's a little bit different intravenously, but outside of research protocols, nobody does that. Um, so you give yourself a subcutaneous injection of Gonadorelin. Typically, these clinics are using like 100 to 200 micrograms. And so you get a rise in Gonadorelin in your system, GnRH, with a half-life of like 10 to 20 minutes. That in turn stimulates both LH and FSH to be secreted by the pituitary gland. And that sounds great if it weren't for the fact that the half-life of LH is like 20 to 30 minutes, and then the half-life of FSH is like 3 to 4 hours, give or take. Yeah, it depends on which source you look at. So what you're looking at is these little blips. So you get this short little burst of GnRH, Ganirelix, when you inject it, and then you get a short little burst of LH and FSH. So basically, at least as far as LH is concerned, which is crucial for maintaining the high levels of intratesticular testosterone that are required to form sperm, especially the first half of sperm production is very much dependent on LH production. The finishing off of the sperm and is more FSH related, but obviously they're both important. So you get, after 4 hours, your LH levels are basically back to baseline or pretty close to it. So it's not sufficient to maintain adequate fertility. And so, physiologically in the body, what happens is that throughout the day, you have pulses of GnRH, every 60 to 90 to 120 minutes. It varies by person and by time of day, more in the early mornings than in other parts of the day. But, the point is you have these like multiple little bursts of GnRH throughout a 24-hour cycle, which in turn lead to little pulses of LH. And essentially you maintain like a steady amount of LH that varies throughout the day, but is always present. And the same with FSH. And that is what is required in an intact HPTA axis, assuming you have normal, healthy testicles. That's what's required to maintain adequate sperm production. So you have to have GnRH signaling multiple times per day. And if you look at the studies with Gonadorelin, were effective in men with hypogonadotropic hypogonadism, so low LH and FSH levels, which is exactly what happens when you're on TRT. It's only successful when they pulse dose it. So they either do multiple injections per day, like up to 5 injections per day, if not more, often every like 90 to 120 minutes, or they use a little device that's kind of like any of you guys out there that are type 1 diabetics that have an insulin pump. Kind of like an insulin pump. So you wear it and you load it with cartridges of Gonadorelin, and then it gives you a pulse dose of like, I think they use somewhere between like 5 and 20 micrograms, every 90 minutes, give or take, throughout a 24-hour cycle. And that mimics the GnRH pulses that the hypothalamus makes. And when you do that, yes, you do get fertility. But that's not how these clinics are dosing this stuff. They're dosing it essentially like they were dosing HCG, which is typically like twice a week. I've seen some of them that do it 3 or 4 times a week. But again, not sufficient, right? Not sufficient. In order to maintain fertility, adequate fertility in a man, you have to have both LH and FSH, or you have to have an LH/FSH analog, some other substance that binds to the receptors that activates them in a similar fashion, okay, which of course is HCG, right? It binds to the LH receptors. It is not LH. It's not even remotely like LH, but it does bind to the receptors. And assuming you have adequate testicular function, in many men on TRT, it is adequate, often in monotherapy, to restore fertility, but not always. This is not 100%. So a lot of men, in addition to HCG, they need another agent, specifically something that has FSH in it. And most commonly, that's recombinant FSH. You'll see sometimes protocols where they add HMG. And this sort of thing is, I can vouch for it clinically. It's worked for me. And it's worked for many, many of my patients, and many of my physician colleagues with their patients have used HCG with recombinant FSH and or HMG with good results. But the literature is very clear on this too, that it's a viable strategy. There are no papers, zero, that I can find that have ever shown twice weekly Gonadorelin injections, which is, again, the way that these clinics are prescribing this particular agent, to be successful in restoring fertility in a man who is on testosterone replacement therapy. So zero data to support this. And physiologically, it makes no sense once you understand the half-life of GnRH slash Gonadorelin and the half-life of LH and FSH. These little micro pulses of LH and FSH that you get with this twice a week dosing protocol are going to be totally insufficient to restore adequate fertility in the vast majority of men. Now, one of you out there might be like, well, I got my wife pregnant on Ganirelix. Good, good for you. Congratulations. You are an outlier. And keep in mind that many men who are on TRT alone, some of them can still father children, right? So that's why we don't use testosterone as birth control. There are men who still make enough sperm, even when they're taking high doses of anabolic steroids, to maintain some degree of fertility, right? Those guys are out there. If you troll around, you can find stories of men who have successfully fathered children while taking a gram of testosterone a week. That's uncommon, but it does happen. Okay, so, but the point is that Gonadorelin is not going to get the job done, and it really irks me to see that here in 2025 that there are still clinics out there that are prescribing this stuff. It's totally unethical in my opinion, and I don't know, I find it kind of concerning that that there are clinics out there that are doing this. So my buddy is going to one of these. I'm not going to say the name of the clinic, but it's one of these big box chain clinics that has offices like in many states all over the US. And they're a cookie cutter TRT protocol clinic. And on top of that, they're charging him an arm and a leg. Like when he told me what they were charging, my jaw dropped. It was like double to triple what many clinics do. So he's paying all of this money and he's getting crap care from somebody who clearly doesn't know what they're doing. So anyway, that's the thing that concerns me the most. Gonadorelin has no place in a fertility protocol unless you are planning on microdosing it multiple times per day in a pulsatile fashion. There's good literature support for that. So if you want to do that, by all means, go for it. But these days you can get brand name Pregnol here in the United States. It's going to be more expensive. And if you need to use recombinant FSH, it is really expensive because again, it was actually a little bit pricey when we could compound it. But it's way more now brand name. The answer that I have for that is, obviously I'm sympathetic to that. Fathering a child can be expensive, but if you can't afford brand name HCG and recombinant FSH, trust me, you probably can't afford a kid because they are, as any parent will tell you, they're not cheap. And I'm finding that out right now. I've got two under the age of 2 at the moment. They're costing us a fortune. What do I recommend for fertility? Again, the majority of men don't have to come off testosterone. There's always going to be outliers with male fertility, right? HCG is a must, in my opinion. The dosages that you'll see for successful fertility restoration with HCG, they vary widely. So I have some colleagues that really like to microdose it on a daily basis, like 125 units to 250 units every day or even every other day. And there's literature support that can be successful. You'll see like 250 to 500 units either every other day or 3 times a week can be sufficient. In my experience, those lower dose protocols, if the man has completely normal or had completely normal testicular function prior to that, no trauma, no varicoceles, often that's totally sufficient. If the factory or the machinery is damaged for whatever reason, then higher doses might be required. So sometimes in some of the andrology literature, what you'll see is doses anywhere like between 1,000 and all the way up to 5,000 units of HCG, often 2 to 3 times per week. 5,000, I think, in my opinion, is a bit excessive and a bit unnecessary. I don't really think you get much additional bang for your buck past about like 2,500 units. But anyway, if you go on PubMed and search, you'll see some protocols that use up to 5,000 units. I think that's because that high dose is what we used to use, or what is used still actually in the reproductive endocrinology world for women. It's like in IVF protocols. So they use like big 5,000 to 10,000 IU bolus injections. So that kind of stuff has been tried in men. So those all work. But then, you do occasionally have to add recombinant FSH, and that's usually dosed 3 times a week. Monday, Wednesday, Friday is a typical protocol. And it's usually 75 to 150 IUs. And that's actually the same dosing with HMG, so which is a combination of LH and FSH, both, again, extremely expensive, but 75 to 150 IUs, say Monday, Wednesday, Friday. I have personal experience with recombinant FSH at that dose. It was very successful, and I've seen it work wonders in men who kind of have a lackluster response to HCG. They add in recombinant FSH, and boom, their sperm counts will sometimes more than double with recombinant FSH in some cases. So very, very good stuff. So anyway, that's all I have for you guys today. That's my little rant. It just troubles me that we're still having to see clinics do this kind of stuff again in 2025. There's no excuse for it, in my opinion. I hate to say it, but there's really like only 2 potential scenarios that I can imagine that would explain why these clinics and this particular provider is prescribing Gonadorelin for fertility in the way that they're doing it. And number one, and probably the most likely, is that they're just ignorant. They just haven't done their homework. They haven't looked into this before prescribing it, which is obviously a huge red flag to me. It kind of makes you wonder, like, if you're getting this wrong, like, what else are you getting wrong in this man's protocol, and what other gaps are there in their knowledge if they don't understand this concept? And then, of course, the second is that they know, but they don't really care because they're making a fortune off of Ganirelix, which is still fairly inexpensive for them, but they can mark it up massively and sell it to their patients, which is what this particular clinic is doing. They charge extra for it, and they do charge a lot from what I was told. So, it's got to be one of those two. So my advice to you guys is, if you're taking Ganirelix, I mean, by all means, you do what you want. But if you're taking it thinking that it's going to restore fertility to the same extent that a proper HCG protocol is going to, I think you're mistaken. And, my advice, if you have a physician that's claiming that, I would say, first of all, ask for the evidence. Show me the evidence that this works. And if you want to get the evidence yourself, go get a semen analysis. I mean, guys don't do that, but it's like a crucial part of a fertility workup is to get a semen analysis. And ideally, you would do it before you start on TRT. I strongly encourage guys to do that. Almost none of them do, but you kind of really need to establish a baseline. But go get a semen analysis if you're taking Gonadorelin, and you know what? Let me know in the comments if you do that. Let me know what your results are. And if you want to be even more thorough, add an LH and FSH to that. Draw it before your injection and see what those LH and FSH numbers look like. My guess is that they are going to be quite low. So let me know in the comments what you guys think. That's all I got for you. This rant is over. I've got some barbecue I've got to go eat. So I'll catch you guys next time. Bye-bye.